And welcome to today's Journal Club, hosted by the International Society for the Prevention of Child Abuse and Neglect. We thank you for joining us on World Day for the Prevention of Child Abuse today and appreciate all you're doing to help children during this challenging time. In the past year, COVID-19 has highlighted the need to develop, evaluate, and disseminate educational interventions that improve the skills and knowledge of health and social service providers in recognizing and responding to child maltreatment in their practice encounters. Today, Dr. Melissa Kimber will give an overview of the evolving evidence regarding the impact of COVID-19 on maltreatment rates, the available educational interventions for health and social service providers, and which have been evaluated via empirical methods, and a program of research in Canada that is evaluating a novel online educational intervention for providers. Right now, I have the audience on mute to avoid background noise, but we welcome you to please enter any questions or comments you have in the questions box throughout the presentation. Dr. Kimber will respond to questions and comments at the end as time permits. The recording and slides will also be posted on the ISPCAN website for limited time after the webinar. Then they will be archived and available for members only. Melissa Kimber is a registered social worker and psychotherapist practicing part-time in Hamilton, Ontario. She is also a full-time assistant professor and core member of the Offord Center for Child Studies within the Department of Psychiatry and Behavioral Neurosciences at McMaster University. Her research focuses on mental disorders and violence among children and adolescents, including the epidemiology of violence and mental disorders among children and adolescents, supporting practitioners to safely recognize and respond to children's mental health concerns and their exposure to violence, and the development, implementation, and evaluation of preventative interventions. Melissa, we thank you so much for being with us today. Now I will turn it over to you. One moment, please.
Did that work, Heather? I don't see it. Oh, there it goes.
There we go. If you could just put it in presentation mode, I think we'll be good.
Great. Okay. Good morning, everyone. It is really lovely to be here today and to have you all here in the midst of an ever-evolving pandemic and all of the demands that you have on your time. I'm so grateful for this opportunity. I'm just going to turn off my video for the duration of the presentation, but we'll turn it back on during the questions at the end, just to try and prevent any kind of technology challenges. So just give me a second here and I'll turn this off. There we go. Okay. All right. So again, the title of my talk today is Child Maltreatment Online Education for Health and Social Service Providers, Implications during COVID-19 and beyond. And I think, selfishly, I'm actually quite excited to have this opportunity because as I said earlier, this pandemic is ever evolving, and the literature and interventions to address concerns among children, youth, and families is also ever evolving. And so I'm really excited about any opportunities to hear more that maybe I'm not aware about, and the work that you're all doing. Okay. There we go. Okay, so I just want to start off by giving thanks to the First Peoples for the opportunity to meet and learn on their lands. I facilitate this webinar today from my position as an assistant professor at McMaster University. And McMaster University sits on the traditional territories of the Haudenosaunee and Mississauga nations, and within the lands protected by the Dish with One Spoon Wampum Belt Agreement. And for folks that may not be familiar with this agreement, it's one that was made amongst all of the allied nations to peacefully share and care for the resources, including the land and animals around the Great Lakes. The belt uses the symbolism of a dish to represent all of the available resources within the territory, as well as a spoon to represent the people are to share the resources of the territory and to only take what they need. In respect of this agreement, I commit today to making every effort to only taking what I need and giving and sharing what I can with all of you. And I hope that you will also come to this webinar today with the same respect for this agreement. I also just want to take the opportunity to acknowledge ISCAN and the Journal of Child Abuse and Neglect for their interest in and support of our work. And I was especially delighted to be asked to provide this journal club today, given that November 19th, as Heather highlighted earlier, marks the 20th anniversary of the World Day for the Prevention of Child Abuse, which was inaugurated by the Women's World Summit Foundation in the year 2000, with support from the former co-chairs of the United Nations Committee on the Rights of the Child. I feel like the 20th anniversary takes on even more significance given the current COVID crisis and the stress and distress that families across the world are experiencing. And so here are our objectives today. And again, I want to highlight at the very first one, I italicized the evolving evidence because full disclosure, with how quickly new information is coming out, both with respect to public health responses and approaches to mitigating the impacts of COVID-19, but also the empirical evidence related to the impacts of COVID-19. It's impossible, I find, to keep up with it all. And so again, I'm really grateful for this opportunity to potentially hear more about the work that you're all doing across the world. And so we'll talk about what I've come across in relation to the impacts of COVID-19 on child maltreatment rates. We'll provide a very brief overview of educational interventions for health and social service providers, with a particular emphasis on empirically evaluated online programs. And then finally, we'll talk about the RISE project, which it stands for Researching the Impact of Service Provider Education Project. It's a program of research focused on understanding the scope and salience of learning needs and preferences related to recognizing and responding to child maltreatment among health and social service providers in Canada. And a key element of that project is also evaluating a Canadian developed educational intervention called VEGA, which I'll speak more about in a few minutes. And so I thought, prior to getting started with our core objectives, it was really important to start our conversation by raising kind of a cautionary flag. A key challenge in health professions or health and social service provider education related to child maltreatment, and I would argue the child maltreatment field more broadly, is that there's no universally agreed upon definition or classification of child maltreatment and its various subtypes. And this is complicated by the fact that jurisdictions will vary with respect to their legal definitions for child maltreatment and what meets criteria for protection by child welfare authorities, governments, or states. In addition, there's not yet consensus within research or practice about what distinguishes certain forms of abuse, in particular emotional abuse, emotional neglect, from suboptimal caregiver behavior that wouldn't meet the threshold for child protection. And so these I would argue that these are fairly key points when we consider the possibility of developing educational interventions that can be broadly disseminated within and across disciplines, as well as within and across contexts. The inconsistencies in definitions and classification approaches can contribute also to varying estimates of child maltreatment prevalence in the population, as well as contribute to the anxiety experienced by practitioners in relation to recognizing and responding to child maltreatment in their practice. And so from an education scholarship perspective, this creates challenges again with respect to leveraging support for disseminating educational interventions. If we're not clear on what prevalence rates are, it's difficult to make the case, if we're thinking practically speaking, for folks who are really busy already in their clinical practice to take on another education opportunity. And so related to this idea of definitions of child maltreatment and how they vary, I think it's really important that everyone in the virtual room today have an understanding that the definition our team tends to come at our work with is the one that's here on this slide. And so typically we conceptualize child maltreatment to refer to a constellation of adverse parental or caregiver behavior that causes or could cause physical or emotional harm to a child or adolescent. And generally speaking, these behaviors can be grouped under physical abuse, sexual abuse, emotional abuse, physical neglect, and emotional neglect. In addition, children's exposure to intimate partner violence, particularly in Canada, is increasingly recognized as a sixth form of child maltreatment. And I want to say at the outset that I appreciate that this conceptualization of children's exposure to intimate partner violence as a form of child maltreatment can be contentious. And so again, I think because I'm going to be talking about Canadian-based interventions in more detail today, I think it's important that you're all aware of where we come from. And so this refers to, in our context, children or adolescents' exposure to or awareness of any incident of violent or threatening behavior between adults who are or have been intimate partners or family members. It includes physical violence such as shoving, hitting, kicking, etc., as well as exposure to or awareness of adult sexual violence, emotional abuse, intimidation, controlling actions such as isolation, and financial control or abuse that has caused or could cause physical or emotional harm to a child. So similar to the definitional challenges that can impact the development and scale up of educational interventions for health and social service providers, the data from which we can draw estimates of child maltreatment prevalence can also have influence on the extent to which health and social service providers understand the rationale for taking up education opportunities. It's likely no surprise to the folks in the virtual room today that estimates vary based on the source of maltreatment reports and measurement methods, and this continues to be the case in the COVID-19 context. For example, strategies for measuring the extent of maltreatment in Canada and likely elsewhere in the world have included incident studies of first-time reports to child protection authorities, as well as clinical and community-based surveys of youth and adults who are asked to retrospectively recall their exposure to maltreatment, typically before the 18 or 16 years of age. And generally speaking, given that each form of child maltreatment can lack overt indicators of their occurrence, prevalence rates based on reports by professionals tend to be significantly lower than those based on self-reports of victimization. In addition, given the complicated nature of child maltreatment, as well as the fear and stigma that can be associated with these experiences, those of us in the field, and I'm sure many of us in the room would agree, that all current estimates of child maltreatment prevalence are likely underestimating the true rates of maltreatment experienced by children and youth. And so on the right-hand side of your screen here, you'll see that typically those reports that come from administrative data sets tend to provide the lowest prevalence rates. Child and youth self-reports tend to be in the middle range, and adult self-reports tend to have the highest rates of prevalence. And so I just want to start off with a quote here. And maybe I'll just say that the peer-reviewed empirical literature, which evaluates the impact of COVID-19 for child maltreatment, is just emerging. And again, it's evolving quickly. It is really striking to me that even since the paper that we are focused on today was pre-released by the Journal of Child Abuse and Neglect at the end of September, there have been a significant number of papers published in the child maltreatment area. And so it feels like a large task to keep up with the state of the knowledge. But before diving into specific studies, I think this quote really highlights the gravity with which we're trying to navigate this landscape. And so this quote comes from the Organization for Economic Cooperation and Development, or the OECD. And for those who aren't familiar, the OECD is an intergovernmental economic organization with 37 member countries that was founded in 1961 to stimulate economic progress and world trade. And so they aptly state the COVID-19 pandemic brings with it the third and greatest economic, financial, and social shock of the 21st century after 9/11 and the global financial crisis of 2008. And so this quote really maps onto editorials and commentaries which have emphasized concerns related to population level increases and risk factors associated with child maltreatment, including financial and occupational stressors, as well as emotional, relational, and psychological stressors attributable to prolonged periods of social isolation and reduced availability of health, mental health, education, and social services. Specifically, economic trends suggest that COVID-19 has led to a global increase in the rate of unemployment and a fiscal recession. And reports indicate that caregivers who are most likely to be impacted by employment layoffs are also those who are already in precarious financial positions and unable to absorb these unexpected or prolonged financial losses. So we would argue that given previous evidence detailing the strong links between caregiver socioeconomic stress and the risk for child maltreatment and related forms of family violence, including IPV, it's possible that the economic related impacts of COVID-19 may contribute to elevated rates of child maltreatment, although this relationship has not yet been empirically substantiated with longitudinal data sets. A second and equally concerning risk factor related to child maltreatment, which has been found to be elevated in the context of COVID-19, is caregiver-related stress and burnout. Many of you in the room may be experiencing this yourself, and so the absence of daycare, school, and community-based programming for children and adolescents, as well as the loss of caregiving supports, has increased the stress experienced by primary caregivers. And there's previous evidence that tells us chronic and overwhelming parenting stress or caregiving stress is positively associated with couple conflict, abusive and neglectful caregiving practices, as well as caregiver mental health challenges, all of which are also associated with harsh and dismissive caregiving behavior. So despite emerging literature related to these increases in individual, family, and community level risk factors for child maltreatment, to my knowledge, there's no high quality empirical evidence, as I said, longitudinal evidence indicating that the implementation of public health measures to contain the spread and impact of COVID-19 has led to an increase in child maltreatment in Canada or globally. Much of the evidence, which I'm just going to review in just a second, is really cross-sectional in nature, and so it's impossible to disentangle changes in rates pre-pandemic to current pandemic. Within and outside of Canada, of course, though, there have been anecdotal reports of substantial increases in the rate of calls to regional and national level crisis support lines. For example, IPV focus calls to police and social service organizations have tripled in China and increased by over 1/3 in France. This may suggest that IPV, and by extension, children's exposure to IPV, has increased in COVID-19. Similarly, in Canada, we have heard from Kids Help Phone, which is one of our primary sources of crisis support for young people, have noted their concerns related to child maltreatment during the pandemic, and calls to that crisis line have doubled or tripled in many Canadian provinces since the onset of school closures and quarantine measures. And those reports were actually from earlier on in the pandemic. Unfortunately, though, a formal report which disentangles the extent to which these crisis calls are specific to distress related to child maltreatment, and if they've changed at all from pre-COVID to the COVID context, hasn't been provided. There we go. I will say that recently I connected with another colleague at York University, and they were very generous to share some data that's currently under review at a peer-reviewed journal. And this particular data was a cross-sectional survey of 809 adolescents between the ages of 12 to 18 in Canada. And so there was representation from all provinces with the exception of Nunavut. They were recruited from online crowdsourcing techniques, including Facebook, Twitter, and Instagram. And the survey was completed between June 17th, 2020 to July 31st, 2020. They assessed physical and psychological violence via self-reports on a modified version of the Conflict Tactics Scale. And while they're currently working on the prevalence estimates, they have looked at the means of these, or the averages of these scales. And what they have found is that the average is over 1, and based on the coding framework, that indicates that more often than not, or the average youth have reported some form of violence in their home over the course of the pandemic. And so this is one Canadian data set that I know is just coming out, and they were happy to share those estimates with me. And so while I'm not aware of any previous review on rates of child maltreatment during other viral pandemics, a systematic review and meta-analysis led by a group of colleagues primarily located in the United Kingdom synthesized quantitative evidence focused on physical, emotional, and sexual violence against children in the context of natural disasters. They searched 15 databases for evidence published up to May 2018. And they found 11 studies that met their inclusion criteria. 50% of those studies were completed in the context of hurricanes. Majority of the evidence focused on physical and sexual violence exposure and among children and adolescents located in the United States. They did evaluate the quality of the available studies in that review, and the evidence was rated as low quality. Majority of the studies were also cross-sectional. And they did share that there was no evidence of a consistent statistical association or directional influence between natural disasters and violence against children in that evidence. Another review that I can share with you from the University of Social Welfare and Rehabilitation Sciences in Iran synthesized the available evidence focused on child exposure to violence during natural disasters and military conflict. And so similar to the review that we just outlined, the authors synthesized 11 studies, and though they didn't empirically or statistically evaluate changes in prevalence, they did indicate that majority of the studies included physical violence, 2 strictly focused on sexual violence. They did, in a narrative report, indicate higher rates of child maltreatment were perpetrated by family members in the context of military conflict and these natural disasters, as opposed to violence perpetrated by acquaintances. And boys were found to have higher exposure to physical abuse, but girls were more vulnerable to the impacts of physical abuse over the short and long term. And so, unfortunately, I think it bears mentioning that collectively the limited and low quality evidence thus far, I know that there's more robust evidence coming, but the current evidence does preclude our ability to say with any certainty that COVID-19 has contributed to changes in child maltreatment rates. However, I think it is really important to reiterate that up to 1/3 of Canadians, for example, self-report a history of child maltreatment in non-pandemic circumstances. And given that we are seeing clear evidence related to the increase in the risk factors for child maltreatment, I'm hesitant to say that rates aren't increasing. And so I would argue, as during pre-COVID times, and perhaps even more so now with the increase in risk factors, there is really a need to identify and provide evidence-based educational interventions that can continue to prepare health and social service providers during COVID-19 to safely recognize and respond to these exposures in their practice encounters. Unfortunately, an efficacious educational intervention that's capable of improving the health and child maltreatment outcomes of young people and their families via improvements to health and social service provider knowledge and skills has not been previously identified. And so in terms of the educational interventions that have been produced, again, I would encourage folks to review the paper that's tied to today's session for more details. But briefly, these interventions have tended to focus on physical and sexual abuse, as well as practitioners in the United States. They've also tended to focus on the legal requirements for mandatory reporting, as opposed to strategies that one can do to mitigate harms in the reporting process. In addition, and I know that this can be a contentious issue, many of the interventions have tended to focus on screening for child maltreatment exposure, despite what I would suggest the lack of evidence indicating that screening is warranted. And even despite, if there's a good case made for screening, these interventions haven't explicitly acknowledged important contextual factors that are needed to make sure that screening procedures are safe. And so what are some key considerations that we need to keep in mind to move or advance the field of educational interventions for health and social service providers during COVID-19 and also beyond COVID-19? And I think what I'm about to share with you is particularly relevant in Canada, but likely relevant for folks around the world. Canadian health and social service providers work in widely diverse settings. And so those include hospitals, community-based clinics, client homes, schools, etc. Geography in Canada is vast, and health and social service providers practice in urban, rural, and remote areas. And so education needs to consider these contextual nuances in recognition and response to child maltreatment. And unfortunately in Canada, and I'd be curious about elsewhere in the world, there are no national standards for health and social service provider training. And importantly, child maltreatment response in Canada, there's also no national standards for our various providers. And so education requirements for providers vary across the country, and child maltreatment responses, or the perceived necessity of response, varies across scopes of practice. And importantly, in Canada, which is particularly relevant given the limitations of the educational interventions that I outlined previously, in many jurisdictions, we recognize physical, sexual, emotional abuse, neglect, as well as children's exposure to IPV as reportable forms of child maltreatment. And none of the interventions that I've previously examined in the literature address all these forms of maltreatment exposure. And so for all of these reasons, web-based educational interventions that address a multidisciplinary audience are compelling for the Canadian context. And I would argue offers the opportunity to effectively educate a large number of providers across geographical and disciplinary boundaries in a flexible and cost-effective manner. In addition, we know from the education scholarship literature that generally speaking, web-based education is as effective as traditional learning approaches for health and social service providers. And evidence from authors Kenny, Reingold, Smeekens indicates that this is also the case for education in child maltreatment. And so I think this information is especially relevant for COVID-19 context, given that there's no date by which health and social service provider educational institutions and programs can expect to resume traditional learning opportunities or in-person learning opportunities. And so because we have no end date for this pandemic, that leverages an even more heavy case for online education programs. And so I'm delighted to get to this portion of the presentation. This brings us to Vega, which is an online educational intervention that aims to improve healthcare and social service providers' knowledge, attitudes, skills, and behaviors related to safely recognizing and responding to family violence, inclusive of child maltreatment, in Canadian providers' practice. Development of the VEGA intervention and associated resources was led by Dr. Harriet McMillan, who's a close colleague at McMaster University. And VEGA was the first project funded under the Canadian government's 10-year, $100 million investment that was announced in 2015 to support victims of violence and their children. And so, as I said, VEGA addresses 3 forms of family violence, inclusive of child maltreatment, children's exposure to intimate partner violence, and intimate partner violence. It was developed using an iterative design process that incorporated systematic evidence reviews of the family violence literature, environmental scans of existing and relevant training resources, consultation with clinical and research experts in family violence, instructional design, as well as repeated input from 22 national health and social service professional organizations that you see listed on this screen. And so I just want to share with you now, with permission from Dr. McMillan, a video that the VEGA team developed about why it's important to access the VEGA resources. So this just may take me a second to get the video going, so please bear with me. Heather, are you able to jump? Oh, there we go. I'm able to. Just need to get to the slide for the video, and then I think I can click on the link here.
Okay.
Okay.
Hi, I'm Maria. I'm a family doc. I think I'm pretty compassionate. You know, I read the literature and keep up with what's new and the best practices for my patients.
And I'm Mark. I'm a social worker. It's important to support my clients and advocate for their needs. That's why I was so surprised when I became more aware of the huge impact of this one exposure. This kind of exposure is linked to all kinds of mental and physical health problems like depression, anxiety, alcohol, and drug use.
In children, it can affect how brains grow and develop and can lead to all types of problems across their lifespan. In adults, it actually increases the chances of heart disease, cancer, and other chronic illnesses.
It's not a toxin or a virus or a pollutant. It doesn't discriminate. It can affect everybody across all cultures, communities, and income brackets. The kind of exposure we're talking about is family violence. Family violence is a complex issue, and every Canadian family is susceptible. The numbers are staggering. About 1 in 3 Canadians has experienced abuse before the age of 15. A Canadian woman is killed about every 6 days by her current or former partner. We're becoming more aware that men are at risk as well. Transgender people have much higher rates. Over 60% reporting experiences of intimate partner violence, or IPV. You may know IPV as domestic abuse or domestic violence.
There are lots of different words used to describe family violence. With children, it's often called child abuse and neglect or child maltreatment. Another type of family violence is called children's exposure to IPV and involves a child hearing or seeing violence among caregivers or being aware of its effects without actually witnessing it.
Whatever you call it, research shows that physical, emotional, or sexual abuse and neglect can impact all aspects of a person's life, including how they learn, speak, behave, and interact with others.
When I read about family violence, I realized there was more to it, and I really needed to learn a bit more about this. I found a great resource called the VEGA Project. VEGA has created evidence-based guidance, a handbook, and innovative educational resources about recognizing and responding safely to family violence. It's the first time that national organizations, including nurses, dentists and dental hygienists, doctors, child welfare advocates, and a range of others, have come together to develop ways of helping people know how and what to say and do to help patients experiencing family violence. Also,
Looks like it's just trying to reload.
See if that helps. Oh, darn. We rely on technology so much, it has a way of betraying us. Okay, well, you know what? In the interest of time, I'm going to go back to the slides, and sorry about that, folks. For anyone that is interested in seeing the remainder of this video, as well as the Vega resources, I will again provide a bit more information in just a second, but you can go to the vegaproject.mcmaster.ca. You see it at the top of the screen here, and you'll be able to see the rest of the video, but also register to be able to access those resources. I'm going to go over them in more detail now. Okay. So Vega is an online educational intervention that it has developed for the purposes of being self-directed or facilitated via a webinar from a member of the Vega project team. And so again, you can log in and complete these modules at your own pace. If you complete it as a self-paced intervention, it can be completed within about 3 hours. It's guided by what's called the Vega Competency Framework for recognizing and responding safely to family violence. The competency framework is informed by evidence-based models of cognitive processing and details various practice domains and associated core competencies which providers can expect to achieve upon completing the Vega core modules. The core modules are depicted on the outside of this circular diagram here. So specifically, the first module that we ask folks to start with is Know About Family Violence in Canada, and that module provides important information around definitions, prevalence, consequences, risk factors, and causes of the various forms of family violence. Then you have the 2 modules in the middle of the circle of the diagram, so recognize and respond safely to child maltreatment as well as intimate partner violence. And each of those contain how-to videos, knowledge checks, reflection opportunities, and at least one simulation scenario that you can complete to hone your knowledge around recognizing and responding to each form of violence. And then finally, on the right-hand side, you see the 4th core module, which is creating safety. And that particular module is really focused on how do we, in our care environments, ensure that our actions and our clinical setup enhance the emotional and physical safety of the people that we work with. And so that section is informed by principles of trauma-informed or trauma and violence-informed practice. And so what you see on the screen here is just some examples of the content that's in the child maltreatment module. And so we have example scripts for providers, words, because we've heard from folks that they can find it difficult to find the words when they need to talk to folks about different forms of family violence, including child maltreatment. In the middle here, you have 2 different examples of the how-to videos. The top one is a video about a clinician letting caregivers know that they need to make a report to Child Protection Services and models how to do that in a safe and empathic way. The bottom video is a video about a clinician inquiring, I believe, about potential exposure to sexual abuse. And on the right-hand side is an example of those knowledge checks, which is an evidence-informed pedagogical strategy to support providers to retain their knowledge around this content area. So Vega was actually launched in June of this year. And while Dr. McMillan and her expert team have received a tremendous amount of positive feedback from providers encompassing a range of health and social service disciplines, the educational resources have actually not yet undergone a formal evaluation for effectiveness. And so this is where the RISE project comes in. And so the RISE project stands for the Researching the Impact of Service Provider Education, which is a program of work that I am leading and have the luxury of leading in collaboration with Dr. Meredith Vanstone, who's an education scholar at McMaster University, and Dr. Donna Stewart, who's a psychiatrist and expert in gender-based violence at the University of Toronto and the University Health Network. It is also funded by the Public Health Agency of Canada. And really, over the next 3.5 years, the RISE project aims to identify and create implementation drivers for the pan-Canadian uptake of VEGA as a health professional education intervention. And so we're doing that with the current funding, as well as evaluate the perceived value and impact of VEGA to lead to improvements in practitioner recognition and response to family violence, inclusive of child maltreatment, and then eventually to determine whether or not VEGA leads to improvements in the well-being of individuals and families who have experienced or are at risk of experiencing family violence. And that particular evaluation will happen with a future funding opportunity. And so the model of the RISE project will occur over 3 phases. We will be using a mixed method approach that involves the collection and integration of qualitative and quantitative data at multiple time points. And I think critically, all phases of the RISE project are informed by a model of implementation science. And so at this point, some of you might be wondering, okay, why use a model of implementation science to do this work? And so I think that question gives us cause for pause to just look and reevaluate some important terms when we talk about the uptake of educational and clinical interventions into practice. So some of you may be familiar with the terms on the screen, including knowledge dissemination and knowledge translation. Knowledge dissemination refers to the distribution of information via passive or unplanned means. And so an example of this would be, we would send out notices that VEGA is available, and that would be knowledge dissemination. So typically this is characterized by primarily a horizontal process. So it's mediated by our peers. And some examples might be peer-reviewed journals, distribution of reports, research results to peers at academic conferences. Knowledge translation, however, is the process of applying knowledge that was generated by rigorous scientific inquiry. And so if I'm thinking about that in my role as a clinician, I would consider knowledge translation would be my process of implementing, for example, cognitive behavioral therapy with a client of mine because the evidence indicates that that's been evaluated as effective for that patient group. Implementation science is a little bit different. Implementation science actually refers to the scientific study of methods to promote the systematic uptake of research findings and other evidence-based practices into routine education or clinical care. And so to this end, implementation science, instead of knowledge translation or knowledge dissemination, involves a planful, purpose-oriented, and multi-strategy approach for moving interventions into routine practice or education systems. It produces replicable knowledge regarding the processes, the success and/or failure of implementation endeavors that advances our understanding of moving interventions into practice, and extends knowledge dissemination and knowledge translation investigations one step further by actually studying the methods by which adequate dissemination in KT occurs within the applied practice realm. And so why adopt an implementation science lens for education, and more specifically for evaluating the VEGA resources? It's become quite clear that relying on knowledge translation and knowledge dissemination doesn't really do the trick. In fact, accumulating evidence tells us that widespread uptake and use of new clinical and education interventions in the health and social service sectors remains a public health challenge. The relatively low uptake of interventions, despite the fact that we have external advocacy drivers to support their adoption, including organizations and policy advocates that tell us to use evidence-based interventions. tells us that this kind of advocacy and policies are required but inadequate for actually getting practitioners to change their practice. There are now 3 reviews that have converged in their findings and which tell us that relying on knowledge dissemination can translate to an average delay of up to 17 years before an intervention is routinely utilized as it is intended by 50% of its users. And so on the screen here, you'll see when you have effective implementation, which is on the left-hand side of the table, and you have an effective intervention, we have interventions that are sustainable, we have interventions that are high in fidelity, and we'll have good client outcomes. And so I like to just show this video about why implementation matters. And so I'm just gonna, I think this one will work without changing screen.
Asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Hannah, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
And so that's just for those of you familiar, that's from the TV show House. And I'd love to show that clip because there we have kind of this humorous depiction of where implementation, knowledge dissemination, and knowledge translation has really failed. You have this evidence-based intervention, an asthma inhaler. We know that that's effective for reducing symptoms and complications related to asthma, but something happened in the communication of that use of that intervention to the patient that then just resulted in her going through an inhaler once a week and also not reaping the benefits of that actual evidence-based intervention. Oh, pardon me. So I think one of the things to highlight is the extent to which implementation science models and in education efforts can be used to improve the uptake of educational interventions is really an emerging science, and it's really catching up to the clinical science realm. So we don't really know yet if it takes as long to translate education interventions into routine practice as it does for evidence-based clinical interventions. However, we do know from the literature that there are some important drivers of the use of education intervention, and these can be articulated at the micro, meso, and macro level. And so we know that practitioner attitudes toward a particular topic area, as well as towards education, the readiness to change, their learning preferences, and their current knowledge can all influence the extent to which they take up a new education or a new educational intervention. In addition, there's institutional and organizational learning policies which influence the extent to which practitioners can access educational interventions, and that affects the scalability of new education opportunities. And then at the macro level, regulatory college support and accreditation and the widespread availability of an intervention, we also know that that impacts the extent to which these interventions are taken up. And so if we don't consider these drivers of educational impacts, then one could assume that our education efforts are really going to fall flat. And so what does this mean for the RISE project? Well, we don't have enough time to go too deeply into the model of implementation science that we're using, but I can share with you that it's called the Active Implementation Frameworks. It's a model of implementation science that was derived through a systematic review of implementation successes and failures in the areas of education, health, as well as child welfare. And the Active Implementation Framework has good evidence for supporting more rapid translation of interventions into practice, but it's not yet clear if it's going to be as effective in the education realm. And so, given its basis in clinical interventions, we're fairly confident that it's going to be supportive to get Vega out there and used more readily. Importantly, the active implementation framework outlines 5 components for success, 2 of which include a usable intervention, and in our case that's Vega, as well as the development of implementation teams, which comprise representatives of the intended users of the education and who are keen on supporting the take-up and sustainability of the education in their stakeholder group. And so given that information, we're really lucky to be collaborating with 8 national level organizations on the RISE project, which are listed here. Each of these organizations have identified champions of family violence education within their organization and have committed to supporting the implementation and evaluation of Vega among their combined 85,000 physician and 22,000 social work members over the course of the project. And so what is that going to look like? As I said earlier, the RISE project is going to occur over 3 phases. We're currently nearing the end of phase 1. And so I'll just touch on that really briefly because I'd like to share with you some of the emerging findings from that phase. So phase 1 is really understanding the extent of learning needs and preferences among physician and social work providers across Canada, and then using that information to create drivers of Vega's take-up and sustainability in physician and social work practice. And so it's really an opportunity to identify what can be supportive for folks to use Vega and to learn from Vega, and then to take the learning from Vega into their practice. So with respect to that phase 1 opportunity, we are conducting a sequential mixed method exploratory research design, whereby we have a qualitative strand of data collection followed by quantitative surveys to determine the scope and salience of family violence learning needs and preferences among our target groups. Again, at this point, we're nearing the completion of the qualitative component, which was guided by the principles of qualitative description. And for those that may not be familiar with this research approach, it's really a pragmatic approach that's commonly used in qualitative health research to generate a comprehensive summary of perception and experience using the language of participants. And so what this has involved is these semi-structured interviews with nearly 100 social work and physician colleagues across Canada, and in particular in the provinces of Alberta, Ontario, and Quebec, and you can see the breakdown there. Thus far, we have 29 social workers, 14 social work trainees, 27 physicians, and 29 residents across those 3 provinces. I can share with you that the emerging findings tell us from participants that they find it complicated to recognize and respond to intimate partner violence and child maltreatment, and it's further complicated in the context of COVID-19. They have told us that mandatory training and accredited training are facilitators for them to learn more about child maltreatment. With respect to barriers about learning more around child maltreatment, they tell us that time, organizational training requirements, and money can get in the way of participating in education opportunities. And I think something that's really striking is that we're hearing consistently from folks that COVID-19 has actually alerted them to the possibility of child maltreatment, where they prior to COVID-19, they didn't really think child maltreatment was that much of a concern. And so one of the, I suppose, the unintended consequences is that folks have a much higher awareness of the possibility of child maltreatment. And so that's just a really quick overview of where we're at in the RISE project. To recap more generally about what we've talked about today, we're seeing population level increases in the risk factors for child maltreatment. We know that health and social service providers play an important role in identification and response, including initiating protection via mandatory reports, and they feel really challenged by this. And the sense is that this is even more important to understand and do well in the virtual service provision world where confidentiality and safety can look very different. And online education that supports recognition and response among health and social service providers offers a really important opportunity to support children, youth, and families in COVID-19 and beyond. And so I think I will stop there and just thank you all for your attention. And I've included my contact information there at the bottom of the screen. And I'll now turn my video back on for the few minutes that we have for questions.
Okay, great. Thank you so much, Melissa, for sharing this information today, and congratulations on all the great work that you're doing. We have a few questions, and if we don't get to your question today, I wanted the audience to know, please reach out and we will try to connect you with Dr. Kimber and get that answered as best we can. So this question is asking about tailoring online education materials to the reality of virtual delivery of child maltreatment services. She's also asking, what do you think should be considered as the new red flags of maltreatment observable through virtual interactions?
Yeah, that's a great question. So I will say that Vega was developed in the context of when in-person interactions were still the norm. And so there's not explicitly content in there to consider what might be different in the online virtual world. Clinically, if I'm speaking from my own perspective as a clinician and what I've been looking at for other related projects, is I think assessments of safety and confidentiality need to be a bit more creative. And so, you know, when the context of our practices, we can control more so who's in the room when we're doing the work. We can ask people to leave and have a little bit more control over that. And so when I'm doing virtual care with folks in their home, that's much more challenging. And so what I've typically done is actually asked clients if they're comfortable, young people, is to show me the room on their camera, just so I can get a sense of, is there anyone else that might be lurking around? So that's one thing that I've done. I've also used the chat function a fair bit. And so as usual clinical practice, I meet with youth alone from their caregivers, and I meet with each caregiver alone if it's a two caregiver environment. And in those sessions, I alert them to when we are in family-based work, feel free to use the chat function, or when we're alone and they're worried that someone might overhear them, feel free to use the chat function. I don't know if that addresses all of the question, but those are just some of the things that came to mind.
Great. Okay, thank you. This person is asking if any of the Vega resources address prevention, and if you could speak to how to work with families to prevent the problems in the first place.
Yeah, so that's a great question. So Vega is not I wouldn't say it's a primary prevention tool. I feel like that question is best for Dr. McMillan. Certainly, it's for the prevention of recurrence and associated impairment. And so the idea is to skill up providers so that we can recognize it as quickly as possible and intervene in appropriate ways so it doesn't happen again. And also, if there's indicators that child maltreatment could happen, one could say that that's a primary prevention lens if child maltreatment hasn't already happened.
Okay, thank you. This is a comment related to integrating programs across sectors. For example, she says gender-based violence and child abuse or child maltreatment often occur at the same time and in the same location. And she's asking if you could share a case or an example of such cross-sector cooperation that you know of.
Mm-hmm. So are we asking for like a clinical case example, or?
Yeah, she doesn't say specifically. Yeah, I guess her comment is just, you know, the importance of integrating programs, and if you know of maybe successful people doing that successfully.
So certainly, it's explicitly acknowledged in Vega, for example, that oftentimes when we're thinking about IPV, women are disproportionately the victims of that experience, and by the continued disproportionate role that women have in caregiving for children. When we think about violence being in the home and IPVs occurring, that affects both the women and the child. And you know, there's quite an acknowledgement that mandatory reporting around IPV can be really unfair in a lot of circumstances for women, and so women who are experiencing IPV. And so that's explicitly acknowledged in the VEGA resources, and there are strategies in VEGA around how to make reports that are respectful of that interconnection and the need to provide women survivors of IPV resources at the same time as making those reports. So I don't know if that entirely answers the question, but I would say that is addressed explicitly in VEGA, and encourage you to take a look, and we can have another discussion about that.
Okay, thank you. And then maybe if I could just finish on one more quick question here. I know we're just a bit over time, but this person is just asking if your team has ever considered adapting VEGA in any way culturally for low and middle income countries.
That's a great question. I think that is definitely on our mind. And so we haven't yet, because we don't actually know. It hasn't been empirically evaluated yet. And until we know whether or not VEGA as is effective and in changing knowledge, attitudes, skills, and behaviors, it would be premature to start adapting. We are undertaking a smaller, focused qualitative evaluation with Indigenous service providers on 6 nations of the Grand River territory. And so that's the extent of the work that's happening right now. That's explicitly attuned to specific cultural needs. But other than that, we're holding off until this evaluation is done before we consider any major adaptations.
Okay, all right. Thank you so much. Okay, well, we are at time, so I just wanted to say thank you again to everyone in the audience for attending and for your questions today. And again, if you have a question that didn't get answered or you think of something you'd like to ask, please reach out to us. I can be reached at resources@ispcan.org, and we will do our best to get your question answered. So now I'm going to show my screen again for a couple concluding slides. One moment. Okay, so we would like to encourage you to become a member of ISPCAN if you are not already, so that we can continue having webinars like these in the future. Our member benefits include a subscription to Child Abuse and Neglect, access to our past webinars and other educational resources, the ISPCAN Child Abuse Screening Tools, and free and discounted virtual trainings and conferences. We offer several membership levels starting at $35 a year for our associate membership. We also invite you to visit ISPCAN's COVID-19 resources page for a variety of resources for professionals, parents, and children. You'll also find information on upcoming webinars and trainings, including our series on how to get published in partnership with Elsevier. The next two are December 1st and December 8th. So to learn more about ISPCAN, please visit us at ispcan.org. And a reminder that a recording and the slides from today's webinar will be posted on our website shortly. If you have any questions or comments about today's webinar or upcoming webinars, please reach out at resources@ispcan.org. Thank you all again for joining us today. Stay safe and healthy, and have a great day or night, depending on where you are. Thanks so much, Melissa.
Thank you. Have a great day, everyone.
Thank you. Bye-bye.
Bye.